good evening to everyone. A very good evening to all the esteemed doctors who have joined us today across the globe on this lovely Sunday. I am Artika Rajpal, business head from Alembic Pharmaceuticals. With me, I also have the presence of Yogesh Patil and Atul Suri. As it is rightly said, doctors, you would agree to me that knowledge has no boundaries. With the fantastic and overwhelming response on KBB1, which was Knowledge Beyond Boundaries, where we saw 6,500 doctors log in across the globe, today we present to you KBB2. Alembic is always in the forefront in providing knowledge and scientific platforms to our doctors. I'm sure you all will find today's webinar very informative. With this, I would like to hand over the session to Dr. Chauhan, which is a very well-known face across India. Dr. Chauhan is the unit chief of Sion Hospital. He's also the national coordinator for Foxy Medical Disorders in Pregnancy. I would also like to add that he has been the chairperson Foxy Oncology and was the secretary of MOGS for the period 2019 to 2020. With this, I would like to hand over to Dr. Chauhan. Sir, you may please start. Thank you.
Thank you, Ms. Rajpal. And I would like to take the pleasure and honor to welcome all the delegates who have come from India, all the peninsulas and Southeast Asia. Apart from this, we are also live going to Latin America and Europe. So we have with us today presentation on AUB, Medical and Surgical Management, which is sponsored by Alembic, and it is supported by Science Integra and Maharashtra chapter of Indian Association of Gynae Endoscopy. So I welcome all the speakers. So we have none other than from Korea, Dr. Yoon. Dr. Yoon is from Korea. He is a member of Angelot Women's Hospital. He is the director of OBGY and the head of HIFU Tumor Therapy Center. Welcome, sir. Can I have the next slide, please? We also welcome our president of Foxy 2019, Dr. Nandita Palshetkar, and current president of AMOGS. She is a professor in OBGYN and also D.Y. Patil Medical College. And we also have to know that she is the director of 9 Bloom IVF Center. Welcome, Dr. Nandita Palshetkar, madam. Next slide, please. Dr. Shanta Kumari, madam is president-elect 2021. She is a senior consultant at Yashoda Hospital, Hyderabad, and has donned many hats, one of them being the chairperson of Foxy ICOG 2018, secretary ICOG, and currently she is a member of FIGO working group on violence against women. Madam, welcome. Can I have the next slide, please? Dr. Prashant Mangeshikar, sir, is the first Indian to perform laparoscopic hysterectomy in India and Asia. He is the pioneer of laparoscopic gynecological surgery in our country. And we all know that he was the past president of IAGE, and is presently the vice president of Asia Pacific Association Gynae Endoscopy, APACH. Welcome, sir. Next slide. Thank you. Dr. Krishnendu Gupta is from East. He has done MBBS from Mangalore and MD from Manipal. He is FRCOG London and professor and unit head at the Vivekananda Institute of Medical Science, Kolkata. We also know him as a chairperson of ICOG 2016, and he has represented Foxy at AOFOG 2020 to 2021. Welcome, Dr. Krishnendu Gupta, sir. Next slide, please. We have in the Q&A session Dr. Rajendra Singh Pardesi, a very dynamic leader who is presently based in Aurangabad and is the vice president of AMOGS. And he was also the chairperson of Food and Drug Committee. Welcome, sir, for this Q&A session. With this, we would like to request Dr. Yoon to start his lecture on FUAS. Thank you so much.
Nice to meet you, everyone. Wait a moment. Okay.
Please go ahead. You can share.
Okay. Can you see the screen?
Yes. You all need to know that we are working with different bandwidths across the length and breadth of this country. So there is a possibility of connection dropping, but do not panic in such a situation. And we are there with you, Dr. Yoon. Thank you to be there with us.
Okay. Good evening. This is Dr. Yoon speaking from South Korea. First, I would like to thank the Indian OBGYN Society for giving me speaking opportunity tonight. Because of COVID-19 virus, many offline conferences have been canceled, and online conferences like today webinar are very popular in Korea also. I had several times presentations in China and Hong Kong and Japan, but it's my first time speaking online, so it's very nervous. And second thing is I'm not very good at English at all because I'm not native speaker, so communication is not going to be very smooth. So I will open my personal email address at the end of the speaking. So please contact me freely I will reply as soon as possible. Today, I will talk about the effectiveness and safety of FUAS. That means focused ultrasound ablation surgery on benign uterine tumor. I saw Dr. Lee's presentation on last webinar. He introduced almost everything about HIFU. He talked about principles, difference between MRI guided and ultrasound guided HIFU, and advantages. There's advantages. So today I will talk about the basic principles very quickly and introduce some papers and finally share my experience by case presentation. I think slides do not pass the second page now. You know?
Please share it again. Dr. Yoon, we can see you. Please share your presentation. Welcome.
Okay. So can you see my slide? It's the second page now.
Yeah, we just saw, but it has gone. So would you please share it again and continue sharing it?
Okay.
You need to press the share screen button, which is
I
down.
did already.
Yes, and then go on slideshow.
Right?
Yes, we are seeing it. Very good.
Okay. So I'm the chief director of the Angela Women's Hospital, and my hospital was established in February 2017. I'm with 12 doctors, 7 OBGYN, and 3 general surgery, 1 pediatric doctor. My area of expertise, FUAS, single port laparoscopy, hysteroscopy, female intimate medicine, female intimate gynecoplastic surgery, and female laser. So I'm one of the 4 vivid key doctors in Korea. Can you guys see my slide?
No, we are not able to see your slide. Dr. Yogesh Patil, can you switch off your video?
Already did, sir.
Yeah, so nice of you. Thank you. Dr. Yoon, please share your screen. It is coming and then it goes again.
Okay, I will do again. I did already.
Yeah, we are seeing it now. So keep it that way. Fine.
Okay.
Continue.
Okay. So I used the term the FUAS. Actually, the FUAS and the HIFU is we use it interchangeably. So International Society of Minimally Invasive and Virtual Surgery decided to use the FUAS officially rather than the HIFU. And the basic principle is very simple, because on a sunny day, when you gather the sunlight together with a magnifying glass, the heat energy is concentrated through and strong enough to burn the paper, right? So remember that if the focus area is large, focus margin is not clear, the paper won't burn. So many money is good, large gold is good, but focused area is good as smaller as possible. So mechanism is very simple also. We know the ultrasound is a form of vibrational wave. It can transmit living tissues without damage, and this makes it possible to use the therapeutic purpose. In concentrated focus, temperature will rise up to levels which the tumors are burned, resulting in tissue ablation. This technique is known as high intensity focused ultrasound, HIFU. So when I do the HIFU, there is a very small focused area, but there's no damaged tissue in front of focus. That is important. And then in focused area, the temperature will be up more than 65 or 10 degrees Celsius. So now we know that the HIFU is effective not only benign tumors like uterine fibroid and uterine adenomyosis, also the cancers like liver, kidney, breast, pancreas, bone, soft tissue, metastatic cancers. All HIFU machines are same. I don't agree with that. There are at least 20 HIFU manufacturers, but only few companies have patent rights. It means HIFU machines are not same at all. If the focus area is small, a short exposure time, maybe 1 or 2 seconds, is sufficient to burn the target. But if the focus area is not small, we need a long exposure time to get therapeutic level, more than 20 or 30 seconds. So eventually treatment time becomes longer. The patient is tired and doctor is very tired. The chunking HIFU is only the acoustic lens type. The rest are element array types. Here is the table showing the difference between the chunking HIFU and rest. Actually, the last time doctor explained everything. I just want to say the HIFU, the MRI guide HIFU is only controlled by the interventional radiologist, not all the trained doctors. That's why I choose that's one of the reasons I choose the ultrasound guided HIFU, not the MRI guided HIFU. Here's the picture of my hospital. It's a HIFU center. Chongqing HIFU JC 2000D has been in use since May 2017. I have treated over than 500 patients, and I treat about 10 to 20 patients per month. And JC 2000D is specialized for benign gynecological tumors like fibroid and then adenomyosis. This system is a real-time monitoring ultrasound, and then the patient is carefully placed in the prone position, and transducer diameter is 20 centimeters. So when patients get in the hospital the first day, pre-FUAS MRI is taken on the first day, and the setup treatment plan and do FUAS on the second day. The post-FUAS MRI is taken and discharged. Actually, the day surgery is possible, but the insurance company of Korea gives 90% of the treatment cost if the patient is hospitalized for at least 1 day. The next slide is papers. Actually, plenty of papers on the treatment of HIFU have been published. I will introduce some of papers. This paper is published in 2012 by the Dr. Vincent Chung, who are the work in the Queen Mary Hospital, Hong Kong, University of Hong Kong. Title is Sonographically Guided HIFU for Management of Uterine Fibroid. This paper provides an overview of a background, clinical use and treatment outcomes of sono-guided HIFU in the treatment of myeloma. Table 1 summarizes the background information of each article. Of these 8 articles, 6 reported the degree of fibroid volume reduction, and 4 reported symptom improvement. Table 2. You guys, can you see the table 2 now?
Yeah.
Yeah, okay. Table 2 shows the degree of volume reduction after FUAS. Here 1, 3, 6 papers were based on Chongqing HIFU. The others are non-Chongqing HIFU. So the months after 3 months, the volume reduction is vary from the 45% to 47, and after 6 months, 59 to 68, and 12 months 78, and after 2 years 90%. But I believe that the purpose of HIFU is not only size reduction, but also the symptom improvement, so we can give a good quality of life. Table 3 shows symptom improvement of the 4 studies that describe the symptom improvement. Most patients reported quite good the result, and the improvement seems to increase over time. So 163 is a Chongqing HIFU based report. After 3 months, the patient said that their symptom improvement rate was 48 to 71, and 6 months later, 50 to about 90%. And next paper is about the adverse reactions. Chongqing Medical University published a good paper on the adverse reactions of HIFU in 2015. The case number was large, 9,988 cases. 1,062 patients present with 1,305 adverse reactions. According to the SIR classification system, 1,228 patients are as a SIR class A, that is no therapy, no sequence, and 45 patients as a class B, nominal therapy, observation, no consequences. 26 patients as a class C, required with therapy, minor hospitalization, less than 48 hours, and 6 patients class D, the prolonged hospitalization over than 48, and there was no patient on class E and F. The next slide is table 4, description of adverse reactions. Vaginal secretion is very common, not common, a little bit much than the other adverse reaction. It's only the 874 number, that patient. And then the lower abdominal pain was 225, and lower abdominal pain, the leg pain was 76, the hematuria 52. It's not many. I have experienced some of the adverse reactions in my hospital. I treated already more than 500 patients. Vaginal secretion is very common. There's only one case of the fever of unknown. I gave her 2 weeks antibiotics and she was okay. And unfortunately, there was only one case of a small bowel injury. It confirmed after 1 week FES, because that the small bowel injury do not have the symptom. So she didn't have any symptoms. So that's why I found her the bowel injury very late. But she was okay, repaired by the general surgery in my hospital. And there was 1 degree skin burn, and there was no severe sciatic nerve injury. Next paper is comparative study HIFU versus laparoscopy. The author concluded that compared with the laparoscopic therapy, he insisted that the HIFU has fewer side effects on patients and requires no general anesthesia or blood transfusion. I never do transfusion at all, and leads to quick post-operative recovery and improved quality of life for patients. Next slide is here. I will share my experience with a case-by-case presentation. She is case A is a 37 years old woman, and then she got the laparoscopic myomectomy in 2005. She complained were menorrhagia and dysmenorrhea. Here is the T2 images, and there is a small myoma backside, 2.7 centimeter, and then posterior wall depth was 4.5 centimeter. These images are all the pre-HIFU T2 images. Next slide is a pre-T1 image. T1 image is used to check the perfusion of the tumor and compare before and after HIFU, and to judge the effectiveness of treatment. Left image, there's a full uptake of contrast, but after HIFU, this is endometrium. There's some secretion here, fluid collection, and then there's absent contrast uptake with the intact surround the serosa of uterus. The 2018 August 27, the size became the posterior wall depth changed 4.5 to 2.8 centimeter. Myoma size reduced 2.7 to 1.28 centimeter, and her symptom, mainly dysmenorrhea, was improved. Case B is a 43 years old. She was unlucky until she met me because she had 2 straight non-chonking HIFU treatment before, and then she got especially when she got the second HIFU. After HIFU, she got the 6 straight GnRH agonist injection from April to August 2017. Even she got 2 straight HIFU, she didn't have the symptom improvement. Here is an image of the pre-HIFU sagittal T1 scan. The blue dotted line is actually the margin of the myoma, and the absent uptake area is a remnant, not remnant, the previous HIFU. But I think the fractional, the ablation ratio is less than 50%. Next slide is a pre-HIFU, and this is the right image is a post-HIFU sagittal T1 scan. The size of the myoma was almost 7 centimeter. I did the HIFU on the February 27, 2018. The fractional, the ablation ratio is more than 90, I think. And then June 11, 2018, there was no dysmenorrhea. Menstruation amount was very small. And here is the myoma size became the 3.2 centimeter. And there is a small cavity here. And then about 6 months later, cavity became smaller, and then myoma size is much smaller now. And there is actually the Korean term word 빈궁마마. The bin means no, gung means uterus, mama means queen. The next patient said, without my uterus, I'd rather die. Koreans traditionally believe that losing body organs is against the parent's faith and God. Case C is a 50-year-old woman. Actually, she was a farmer. She said she can't walk because of dizziness. Hemoglobin level was 8.2 grams per deciliter. And she got also 2 HIFU, non-chonking HIFU treatment before. Her chief complaint was menorrhagia, and you can see here's the image of T2 images. There are anterior wall depth was 3.9, almost 4 centimeter, and posterior wall depth was 3.8 centimeter. The funny thing is that there are no absent contrast uptake area right here, center to left. So where is non-perfused area? I did a great job here. Pre-sagittal T1 scan. After HIFU, you can see the absent contrast uptake area here. Actually, after HIFU, she didn't visit my office yet, but I surely know she is okay because she is sending several patients with similar symptoms to me. The case D is about the huge myoma. Many people think HIFU will have no effect on huge myomas, but I believe HIFU is effective no matter how big the myoma is. She is a 46-year-old and single nullipara. She had a urinary frequency, chronic back pain, chronic pelvic pain, and menorrhagia. Here T2 images. Here the blue area, arrow means the uterus is pressing directly on the spine. That's maybe she got the chronic back pain. Also the yellow arrow is uterus pushing the anterior abdominal muscle. But I think it's not easy to find out the urinary bladder. I think this very white thin line is maybe the end of the urinary bladder, I think. The AP diameter was 16 centimeter. I put an imaginary line between L5 and S1. Before HIFU, on February 20, the uterus was over the imaginary green line. After 6 months, the uterus becomes smaller, much smaller, so under the imaginary line, and you can see the abdominal muscle back toward the uterus, and there is a space between the uterus and then sacrum, and you can see the bladder here. So her urinary frequency was disappeared. She is now very satisfied. Can you see the case E slide? Everyone?
Yeah, it is visible.
Okay, I'll continue. Here is a uterus now, and there's a degenerated myoma because this is a T1 image. This is maybe the size was around 4 centimeters. The main problem is why she has a menorrhagia was there is a very small, tiny 1.5 centimeter submucosal myoma, but she wants a baby. It means I need to keep the endometrium safe. So November 9, 2019, I did a great job, and you can see there's no damage in the endometrium because we can know because there's no absent contrast uptake. And the next day, I did a hysteroscopic myomectomy. Here is the images. Actually, this myoma looks big, but as you know, guys, we use hysteroscopy. Usually, the camera is very small. Maybe diameter is 5 millimeter. And here, blue dot line was the root of the myoma. The real picture of photography was this one. I mean, myoma was very small. So next year, this year, January 1st, she came to me, and then I measured the AP diameter. It became 6.5. Before, it was 9.2. amenorrhagia was improved. I usually recommend that pregnancy attempts are recommended from 3 months after FUAS, and then we can encourage them get the normal vaginal delivery because it's very safe. I think this is the last case. She is a 48-year-old woman. As you see, there is a very big mass in the center of the uterus. The yellow line, yellow arrow shows the linear thin the endometrium. The myoma size was 9 centimeters. What will be your treatment plan if the patient has anemia and the big center maybe of submucosal myoma? Normally, hysterectomy was recommended, but I did HIFU, not hysterectomy. Here, T1 images, pre and post, the color change. There was no absent the contrast uptake. I think ovulation fraction ovulation ratio is more than 95, I think. And then actually there was no need to do the diagnostic hysteroscopy, but she came to me yesterday for the routine check, and then I told her for academic purpose, so she agreed with doing the hysteroscopy. I took the picture yesterday. This is seems the color is very gray and no reddish, and then it seems like they have no vitality, right? So after 1 year, hemoglobin level became the normal. Now she was 13. I checked it yesterday, and the myoma size I took today morning. The size was about 3 centimeters. But previously, initial size was 9. So she certifies so much now. So advantages of HIFU is one is a good quality of life, short hospital stay, 1 or 2 days, short recovery time. 1 or 2 days after HIFU, she can go travel or she can walk. Yeah, and then there are little adverse reactions, low risk of infection, low risk of adjacent organ injuries, bladder, bowels, less post-operative pain. Last slide for the markets in the HIFU centers. There are a number of HIFU center of Chongqing HIFU center is 21. Small clinic-based HIFU center is 10, and 8 out of 10 is in the Gangnam district in Seoul. You guys know that Gangnam, because it's very famous by song Psy, world famous singer Psy. And women's specialized hospital, like my hospital is 8, and general hospital is 3. And most of HIFU doctors are OBGYNs, few general surgery doctors, but there are no radiologists for the Chongqing HIFU. And cost, because some ask about the cost, and laparoscopy here, 1,200 maybe US dollar, and Da Vinci robot surgery, 7,000 US dollar, and HIFU is start from the 5,000 to 150,000 US dollar. It's depending on the how many we treat her for the HIFU, how many times we do treat the HIFU for one patient. So it can be very good income to doctors. And this was my last slide. Thank you, everyone. And then please contact me if you have any question. There is an email address here. So I will reply as fast as I can. Thank you, everyone. I'm finished.
Thank you for the wonderful presentation, Dr. Yoon. It was really nice. very informative.
Yes.
Dr. Yoon, it was a wonderful presentation. Sorry, there was some glitch of network, but the way you have presented the cases and all the details of various ages and how the fibroid less than 5 centimeter, less than 10 centimeter, you have used HIFU, and the collection of cases were amazing. The photographs were excellent, and
Thank you.
you have done more than 500 cases, and we are very happy to have you. And it was a wonderful presentation. Today, we all doctors are nothing less than warriors. We are corona warriors. We are sitting in our places, our hospitals, our audience is also warriors. I would like to show one video here celebrating and thanking the warriors, which each one of you are there, helping the government, helping your nations across the world to see how we can resolve this issue. This is a very important day for us, and I would like to share a video which we have got, and it is thanking the doctors, thanking those people. I request Dr. Yoon to please stop sharing your slides so that we can go ahead with the video presentation. Thank you, Dr. Yoon.
Okay.
This is the small this is the small video where the Indian Air Force salutes the doctors praying from above these hospitals, which are become the icons of the nation, helping to reduce the corona in our country. The healthcare workers are the one who are the most important one, apart from the police force and the other essential services which are taking into consideration. And each one of you is a part of it. And we are very happy that the government has done a wonderful job of, putting flowers on all of us and acknowledging our services. Madam, thank you, all of you who have joined, especially giving your valuable time, and Dr. Yoon from Korea. Now we would like to start with our questions, and I welcome Dr. Nandita Palshetkar, Madam, Dr. Shanta Kumari, Dr. Krishnendu Gupta, and Dr. Rajendra Pardesi. We have lined up wonderful questions. I thank again Alembic and Science Integra to get us this live webinar. I would keep my mouth shut now, and I request Dr. Nandita Palshetkar to please go ahead. Thank you.
We have Dr. Prashant Mangeshikar also on with board.
Yes. Madam, I would like to correct here. Dr. Prashant Mangeshikar is also joined with us. Welcome, sir, all of you, all experts. And obviously, Dr. Yoon is going to be with us. I want to tell you that we have got 3,500 users who have logged in on this Sunday afternoon. And it is a fact. Amazing thing. Amazing thing. Thank you so much. Dr. Nandita, can we start your case discussion?
Yeah, hi. Can we have the slides or something? Hello, can you hear me?
Simon?
Yes.
Yes. 1 minute, madam. Meenal is sharing.
Yeah. Okay, I think our first case is pretty simple. She's a 33-year-old infertility patient, low AMH and low hemoglobin also, and a right-sided ovarian endometrioma. Ovarian endometrioma is quite large, 5 by 6 by 8 centimeters. What is the diagnosis? How do you manage this case, etc.? So, Niranjan, you want me to discuss the case, how I would manage it, or you want me
Yes,
to?
madam. Yes, madam. This is the case of infertility with low AMH, which has come to your clinic, and you have already described that she is 33. Means, and she has an endometrioma, which you have already shown on ultrasound. We have that endometrioma. Obviously, you are aware, and we are all are aware, it is a chocolate cyst case. So how
Yeah.
would you go about, madam?
So I think first we must tackle what is obvious, that's the low hemoglobin, and find out what is the reason for her low hemoglobin, whether it's menorrhagia, which is causing the low hemoglobin, or any other reason. So I would do, tests to find out serum ferritin levels, etc., and check out and give her some iron. And if she has menorrhagia, I think progesterone would be indicated in this patient. Now, once I build up her iron, that is very important. So progesterone, I would give it for 21 days, norethistron, for 21 days. And once I've managed her with maybe tranexamic acid for the 3-4 days when she gets a period and get her hemoglobin up, I would definitely like to go for an ovarian cystectomy. But remember one thing, that she has a low AMH. So this is something we have to keep in mind, that there is low AMH. If it's a unilateral endometrioma, 33-year-old, the golden rule is do the surgery. But again, the surgery must be done by an expert. We have Prashant here. He knows the importance of treating the ovary with care, with love, with respect. And I think that's very important because the AMH is already low. So we can, do the laparoscopy and then leave her alone to try and conceive. But here I take a different take, with my 25 years of experience in IVF with a 33-year-old patient, I may just go in for egg freezing before doing the operation. But such a big endometrioma usually suppresses the follicles in that ovary. It does not allow it to grow. So I think in this case, my thing will be progesterone, the tranexamic acid, get her hemoglobin up, do a laparoscopy, and then do egg pooling, so that we can gather the eggs of her eggs, and then we can do the, if she doesn't want to have a child, it's fertility preservation for her. We bank those embryos and leave it alone, and she can even try naturally. She may conceive even naturally because it's a simple chocolate ovarian cyst. If the tubo-ovarian, relationship is normal, it would be great. And I would rather use progesterone post-operatively if she doesn't want to have a baby very soon, to prevent a recurrence. And it'll also take care of a menorrhagia. One more thing I forgot is an endometrial biopsy. That also is important because it helps us to kind of check what is the reason for a menorrhagia. And of course, that she's not PCOS, if prolonged periods, and again, there can be endometrial hyperplasia. So all those things we need to keep in mind when we're treating her.
Madam, you said about egg pooling and egg freezing. So can you just describe that part so that our audience will be in a better position to understand those words?
See, basically, there is a whole new concept. In fact, there is a fantastic paper in Fertility Sterility, April 2020. I was, sitting at home, Niranjan, now we are just reading and updating our knowledge. So it's really good. It's a paper by Anna Kobo, and it says, finally, the decision is out for endometriosis, that fertility preservation in endometriosis is a good idea for patients who have low ovarian reserve. And, they're young because the quality of the eggs that we get is very good. So you can so in these kind of patients, what we can do is, I would actually give her a trial for a pickup first, give her a stimulation protocol. If she produces enough eggs, they will be taken and frozen. And then I would do a laparoscopy. But sometimes this right side ovary may just not respond because the cyst will be compressing the follicles from, they'll be preventing the follicles from growing. So you can actually do, so there are two ways. You do the surgery. After 6 weeks of surgery, I would give her ovarian stimulation, extract all the eggs and freeze them, and then let her do what she wants.
So, madam, I can summarize, that's what I can understand, that following her diagnosis, which is a chocolate cyst with her hemoglobin being low, you would like to build her hemoglobin, which you have said wonderfully, give her drugs so that the reduction of heavy menstrual bleeding occurs with the help of tranexamic acid, NSAIDs, and also put her on progesterone. And then maybe you would like to do a first approach will be a surgery, a laparoscopic ovarian cystectomy, and then with that IVF procedures. Am I right, madam? That's what.
Yeah, if she wants to conceive, okay, because you've written there's no symptoms written over here.
Okay. Dr. Prashant, can you unmute your mic, please? We can see your face and video. Please unmute your mic. It has a red. Yes.
Yeah.
Thank you so much. Thank you, sir. And
Yeah.
sir, since you have come and Nandita and all have come, the viewers have, the users have crossed to 4,005, and I have proof for that. And sir, thank you so much. I would like to thank here Dr. Shanta madam, who just made and I want to tell everyone that, sir, you are an icon. I was your registrar and a houseman 30 years back, and our relationship goes for 30 years ago. But obviously, Shanta madam, your choice was right, and we had to get you. Sir, I want your take on this laparoscopic ovarian cystectomy, sir.
See, first and foremost, if this woman has endometriosis, she can't just be having a solitary ovarian endometrioma. Obviously, clinically, if you look at it, there would be endometriosis around, be it pelvic or be it deep infiltrating endometriosis. One needs to do a proper history taking and an examination. And if required to do, other than the ultrasound, you need to do an MRI to look at deep infiltrating endometriosis. And quite often, it's very rare to have a solitary endometrioma and no endometriosis around. So now you all know that endometriosis does affect infertility, and just by doing a aspiration of the endometrioma is not going to work. You have to get rid of the endometrioma. Well, you have to be careful when you are enucleating the endometrioma. Either you use vasopressin intracapsular so that you preserve the normal tissue, whatever is left behind, because whatever then the cyst wall is already gone and damaged the rest of the ovary. So you need to preserve as much, especially since this woman has a low AMH. But I'm not worried about the low AMH because her problems are also pain. It's not just infertility. You need to get rid of the pain. And unless until you excise the endometriosis, ovarian and extra ovarian, she's not going to feel better. And you can't say, I will get her pregnant and the pain will go away. The pain doesn't go away. And IVF is not magic that everyone gets pregnant. Okay. So my take is first treat the endometriosis. Now, how does one look at the endometrioma? Again, it depends on your school of thought. And from the school in Bordeaux, they have now looked at doing sclerotherapy laparoscopically. I'm not talking about sclerotherapy vaginally because that is not the way to do. So basically what you do is you go in with a Foley's catheter a pediatric Foley's catheter into the endometrioma, inflate the bulb, and then inject absolute alcohol and stay there for 15 minutes. So it scleros everything inside, and then you don't have to do a evacuation of the endometrioma. You don't have to coagulate, right? And then you can go ahead with the rest of your surgery. So this way, you're even helping the woman. For those who believe that enucleation has not to be done, right? And in a debate many years ago, when Donés claimed that you don't enucleate, you only coagulate, and I was the one debating with him. At the end of he finished me off in the meeting because he was with a loud voice said, no, you're killing the patient, you're destroying the endometrioma. And then I had the 2 minutes to sum up. And I said, you must practice what you preach, because there's somebody who's sitting here in the audience who belongs to his team who told me he enucleates every patient. And he publishes that he does not enucleate. So what is in theory is different from what is in practice.
Prashant, I wanted to know whether you drain out the chocolate fluid before
yes,
catheter?
Yes.
And then you instill alcohol. Oh, that's something that we've read vaginally, I'm really
but vaginally you can't because when you do this vaginally, and Dr. Gautam Malabadia has been one of the early guys who did that, and he said all that this does, because he was asked to do this by his senior, is that you're converting a stage 1 endometrioma into stage 4 endometriosis, because everything spills down, and it's good for the IVF people because they like to do IVF then, because everything is frozen. because the
Hey,
ovaries come
let's not
down.
get into the argument there.
I can go on, but let's go on to the next case.
Yeah. Thank you for your
IVF
take on that.
results are very good now.
Thank you. Now we go to Dr. Shanta Kumari, madam. Madam,
Yes,
can we have
Niranjan.
your slides? Thank you. Meenal, can you shift it, please? The next slide, please. Case 2. Yeah, thank you.
Thank you, Niranjan. That was
Yes,
a
ma'am.
good discussion by Dr. Prashant Mangeshkar and of course Nandita. I'm sure down the line now IVF is much better than it was 10 years back, sir. Now this case, I think it's a 30-year-old patient with heavy menstrual bleeding. She seems to have multiple fibroids, again hemoglobin 6.5 grams. She has 2 submucous fibroids, about 2 into 3, and then she's got 2 subserosal fibroids also, 2 into 4 and 4 into 5. Now, how are you going to manage this patient? I think this particular patient, first, what you have to look at is her hemoglobin is 6.5. So you have to correct the hemoglobin. I think at 6.5, I would like to, because she's clinically stable, please go ahead and give her parenteral iron injection. I think ferric carboxymaltose is the right one for this patient. You can give 1000 mg of ferric carboxymaltose IV in 250 ml of normal saline within 15-20 minutes. But most important, remember friends, you have to put your patient on folic acid supplementation and methylcobalamin. Most of our patients have folic acid and with B12 deficiency, because of which the anemia doesn't get corrected. So that increases the hemoglobin better. At the same time, while you wait for the HB to increase, your duty is to see that she gets relief from her heavy menstrual bleeding. So use tranexamic acid, and if needed, you can put her on progesterone. Also, progesterone is very important because we need to buy time for us to actually act, to give her a more definitive treatment. Now we have got wonderful 2 surgeons. One school of thought is the HIFU. We have Professor Yoon here, and we have Dr. Prashant Mangeshkar, who is an hardcore laparoscopic surgeon. Now, what is it that I do? At present, I think what I understood of this HIFU ultrasound guided therapy, even the expert has used hysteroscopic myomectomy. So he has used the ultrasound guided technique followed by hysteroscopic myomectomy. If it is type 0 and type 1, hysteroscopic myomectomy can be done. I'm sure Dr. Prashant will agree with me. And if you are a good hysteroscopic surgeon, please go ahead and you can do your hysteroscopic myomectomy. And as far as the other, can I have the case presentation slide, please? The other 2 fibroids are subserosal. Now, actually, we'll have to ask our Professor Yoon. He has to tell us what are the contraindications, which are the patients where you cannot use HIFU. That is very important. You should know which are the patients you can use, which are the patients you should not use. So as far as I think my knowledge goes, those with pedunculated fibroids and all, better serous fibroids, it's better to avoid HIFU because chance of the injury to the surrounding structures, the small bowel, gut is there. So you have to be very careful. Simple subserous which have a broad base and the size is, they say, around 12 centimeter, lesser one, are more ideal for your HIFU. But in this particular case, when you are doing an hysteroscopic myomectomy, I think any laparoscopic surgeon would prefer to remove the other 2 subserous fibroids also through laparoscopy. And then we'll have to wait and watch. I'm sure after the procedure, the patient will start feeling better, and by then your anemia was corrected. So her heavy menstrual bleeding also may reduce. And I think that is how we need to manage this particular case. All cases have to be individualized. We may be having good lab, I may be a very good lab surgeon, I may be a very good HIFU specialist, provided I have that particular technology in our hospital. So your case selection is of utmost importance. Which case you have to do which one. Individualization of the cases and the affordability of the patient also matters.
Thank you, madam. You have wonderfully described how would you manage this case.
And then, Niranjan, the most important is this patient has come now. She has come in the lockdown period. Now the directive is to lockdown is going to open up soon, and you're supposed to do elective practice. But this patient, if she has come now, your duty is to put her on medical management, put her on your iron, put her on your progestogens
Very
till
good.
she recovers, and then don't do an emergency elective surgery for this patient. Please
Yes.
buy time till the pandemic settles.
Dr. Yoon, we want the comments from you, from your side, from Korea, regarding this small fibroids which are there. There are 2 subserous and 2 submucous. What is your take? Be brief. Thank you.
I think that the symptom is based on not subserous myoma, right? The main problem is submucosal myoma. And then there are 2. And if the doctors, if the patient want a baby, we cannot try the HIFU at all because it will damage the endometrium. So in case, I will give her the ulipristal or GnRH agonist first to reduce the size to do the hysteroscopy.
Okay, thank you.
Niranjan, while we
Yes,
are
sir.
discussing, and Dr. Yoon mentioned, Dr. Yoon, he mentioned the use of ulipristal, and as we go on the 20th of March, the United Kingdom has banned the sale of ulipristal because patients
Right.
develop liver failure.
Right.
And in South Africa, the launch has been cancelled because of the same problems of liver failure in patients on ulipristal. So therefore, we will not be having ulipristal even in India to use. I don't know, maybe that's just a few cases that develop, but then that's enough to cause a cry in the dark that people should be careful when they are giving ulipristal to their patient. But I agree with you that one has to be careful when even one.
Dr. Nandita, can I just ask Prashant sir? I would like to know what is the statement in Indian scenario? What is our drug controller states?
Madam,
I have no idea about what the
in
Indian.
India it is not banned yet.
Yeah.
In India it is not banned yet. So, and there are also cases and there are papers which are saying that it can be used in certain cases of fibroids, especially which are lesser than 3-2, and there is Pearl study. So obviously we are not going to go in that debate now. I know Dr. Prashant, whenever you talk, there is
No, you're not.
debate.
If you can't use it in UK and you can't use it in Europe, in Germany is banned. You should not be using it in India.
Sir, can I just interrupt you? Now I think the world, the scenario is changing. Whatever we use in India, they're using world over. People are asking tons and tons of HCQs, for example, just on the lighter note.
If tomorrow a patient develops liver failure and cites the UK,
this is on a lighter note.
UK, no. If the evidence, then nobody's going to say.
Let me tell you,
Niranjan.
Dr. Prashant, that in this period of pandemic, you have a bigger fan, and it is that fan is none other than Dr. Shanta Kumari, and she's a big fan of yours for cooking. So I want to know, what did you cook today? What did you cook today afternoon?
No, today,
I'm going to come back to you.
We will talk about that.
No. Let this debate be. Or let
Niranjan, just one point in continuation of what Prashant said. I totally agree what he said is true abroad, but there was an advisory that when you want to use ulipristal, you should first do a baseline LFT and then give a chance for 3 months and then see if there is, in certain cases, selected cases, you can try. But right now, he's also correct that in March, they have banned it. So now I'm sure once a drug is banned, like nimesulide is banned long back, but people are still using it. So it's like that. So it will come in our country. I'm sure the Drug Control General of India will take cognizance of it and then do the needful.
I think the drug controller just now is too busy with.
I think, shall we move on to the other management techniques of this? Let's leave this.
So I think Dr. Yoon has answered his Madam Shanta's query. And obviously, if it is a submucous fibroid, we will go for hysteroscopic resection. Yes, Dr. Shanta.
Yes. Can we ask Professor Yoon to tell us what are the contraindications for the use of this
Right.
ultrasound therapy. That's very important. Which patients we should not do? I think a quick answer would help us. And which patients we should do? Let him tell us very categorically who are the patients for this ultrasound therapy whom we shouldn't try.
When I learned the indications from the Chinese doctors, they taught me about the contraindications. One of them was that if the myoma, number of myoma is more than 3, they said they do not treat, but I don't think so. I do not agree with that because now I do multiple myomas more than 10 or 15 numbers. It doesn't matter, but I need to, there is a limitation of the 1-day treatment. It means we do the exposure time is limited. Maybe the maximum exposure time is less than 3,000 times, I think. 3 times second. So when I treat the multiple myomas, I need to do treat once, twice, and 3 times for the hospitalization day. It means the cost will increase. So that's very not good for the patients. So I need to see the wealthy of the patient maybe, but no matter, because the Korean insurance company cover 90% of the cost, so it's okay.
Thank you.
And then there's the very few adverse reactions, so I don't get the stress on treating the HIFU.
Can you tell us what is the, see, you have combined an HIFU and an hysteroscopic myomectomy.
Yeah.
With the cost effectiveness of using both the techniques?
Pardon?
Is it a cost? It is not a cost effective when you're using two techniques.
Yeah. Just to make sure the endometrium is safe. Okay. Or sometimes if the patient have the menorrhagia, even the HIFU cannot control the bleeding control because some patients will have the very small, tiny endometrium polyp. So if one of the chief complaints is the menorrhagia, sometimes I check the hysteroscopy after HIFU to whether she has the polyp or not. So if I found it, I just remove it.
Okay. Absolutely. Fine. Can we go to the next question now, Dr.?
Yeah, Niranjan, just one more question on that second case. Of course, one would do a hysteroscopic myomectomy, and of course, she has got these 2 small subserous myomas. So would it be prudent to leave those subserous myomas alone and get the patient pregnant? Nandita would agree with that.
I can kill you, okay? Even in this COVID, I'll come there.
Can we have the next case, please?
Okay, till we get that case, she puts it on. I think all of you friends, how we treat the patients in our country will be definitely based on our guidelines. Always look at the Indian guidelines, our FDA, our ICMR. Now we have come to know in this COVID time and all, whatever we do for our patients, the Indian way is the best. Okay, please only look out for guidelines of our country in anything which we do. Yeah.
Dr. Krishnendu Gupta.
Yep, thank you. We come to the third case, which is a 26-year-old lady, unmarried, has a 5 into 6.5 centimeters subserosal posterior wall fibroid. So what are the treatment options? Now, it's very important for us to know whether she conceive or she doesn't want to conceive. What are the symptoms? How heavy the bleeding is, if at all she's having any heavy menstrual bleeding. Before we go on to requesting Dr. Yoon to give his comments, if in case she does not want surgery, let's say, although you discuss with the pros and cons of surgery, etc., the medical line of treatment, of course, we just had a little discussion on which is now banned, so we'll not get into that. A lot of people have used mifepristone in low doses for 3 months, 25 milligrams, but fibroid size is rather large, I think, for attempting with mifepristone. We have GnRH analogs, which definitely over a period of time, we've seen 3 to 4 injections will shrink the size of the fibroid to almost 1%. But again, once you do that and once you plan the laparoscopic myomectomy, you know that because of the softness, there's not proper plane of cleavage, etc. And of course, we have the master lap surgeon here. So I think we leave it to him to explain about how he would do that. I'm sure he's got lots of cases where he's operated on after GnRH agonist therapy for 3 to 4 months. Niranjan, you have.
Yeah, I have a video. I have a video to show.
I just want to just ask, if you don't mind, I would like to ask Dr. Yoon on this. Although this is a very good case, considering what you showed us from your cases, that this would be a very good case for your HIFU. But we just got to know the price of the equipment. The price of the equipment is $1.7 million, and US, and that's something like about 12 crores of rupees in Indian money, and it's humongous amount of investment, and then the return on investment. Although you did write that it's a good earning for doctors, but then someone who's investing that kind of money into one particular machine, when you will ever get your return on investment, God alone knows.
That's
unless of course it's somebody
collect
for you.
Collect all of the Foxy will buy one HIFU. Or IAG buy one and then use it.
So Dr. Yoon, could you just highlight, I mean, what if someone comes to you and says, okay, I do not want surgery? Because I think most of the surgeons here will definitely do a lap myomectomy in this case. And so what would your take be?
Okay, the posterior subserous myoma is very good indication for the HIFU. When you do the laparoscopic myomectomy, especially when the position is posterior, it's not easy to remove it, right? Because the vision is not is backside of the uterus, right? So the HIFU is very safe, but we need to very carefully. I need to treat very carefully, because that on the backside there is the posterior subserous myoma will be located in front of the sacrum. So there will be a very famous, the very important nerves like a sciatic nerve. So one of the severe complications is the sciatic nerve injury that will make people cannot walk right. So that's why we take the MRI and then see the distance between the sciatic nerve, the site, and then the margin of the subserous myoma. If the margin is okay, like the safe margin 1.5 centimeter actually. So if there's a safe margin is the perfect, we can try the HIFU very safely. But the main problem is the cost actually. But in Korea, even I told you guys that the Korean insurance company covered the 90% of the cost, but some of them, they do not covered by the insurance. But even they are not covered by the insurance, if she didn't want to be a bingung mama, no matter, no uterus, the woman, they pay the money, because the quality of life is very excellent rather than compared to the surgery.
Okay.
Christian, let us understand that the cost will vary with each and every country. We should not go in that aspect. We are doctors.
Niranjan, can they rent the machine to us?
Yeah, we are in talks with MCGM also, and there are also other places where they are in talks. We should not go in the details of that. We will just stick to the scientific part. It is a well-known point that this machine has been installed in more than, I think, 26 countries, and more than 100 machines have been installed. It is a prerogative, and they are in talks with government machinery. They are in talks with AIMS, as far as my knowledge is concerned. Now, because of this lockdown and because of this corona issue, there are still things are still to be worked up about it, and I'm sure it is a technology. Every new technology which comes is going to have its pros and cons, and everyone is going to have got their own views. So let us not go in that. Let us stick to our country and let us stick to our guidelines. So I think that's more important. Meenal, can we have that laparoscopic video to be shown, if that is possible? And it's very important that once the lockdown is over, we need to go about and do this laparoscopic surgery. I think 1 week ago, we had none other than Lilo Mettler, madam, and she had come from Germany. We had questions also asked to them about laparoscopic myomectomy being done in COVID-19 situation. Can someone play this video, please? So I think it's very important that she told us. I would like to share here with the audience, and obviously we will go to Dr. Prashant Mangeshikar sir also. about his views on that. She showed that we have got those filtration, filtration methods which we are using in our OT. We are having negative pressure OT, and there are various things which we are doing. And now what has happened in Europe is that the lockdown has now come off. Now they don't have lockdown there in most of the European countries. So they have started doing these surgeries and they are taking precautions, learning from the situations of coronavirus, but the procedure is something similar. Now this lady is also having this case of a fibroid, which we can see here. And obviously we have used pitricine. We have diluted this pitricine, and everyone will agree with me that when we are introducing this pitricine inside, we are going to take care and see that there is no bradycardia. There is absolutely slow injection of this pitricine, and once that is done, we can use harmonic or a bipolar and just cut up the uterine serosal wall. Once that is done, you can see the capsule, and once we have a proper capsule being seen, and you can see the whole region being white in color, and that is a very good sign. We will achieve a good hemostasis. It is just pulled out with traction, counter traction, and pulling and tugging it out. The base is now again cauterized, you see, so that the vasculature supply to the fibroid is reduced. And once that is done, we are sure of achieving proper hemostasis. And then we go ahead and coagulate the areas where there are bleeders. There are small bleeders which we take into consideration. This fibroid is then parked anteriorly in front of the broad ligament or posteriorly. Once that is done, then we go on suturing the bed. The suturing has to be done properly. We start from below upwards. I'm just showing the viewers this way of doing a laparoscopic myomectomy, and obviously we are going to use all the precautions which we are supposed to do. We are going to debate also whether we should do open surgery or laparoscopy in COVID times. But in this case, we are going ahead and doing a baseball suturing and closing the serosal area. And once that is done, after achieving hemostasis, we complete proper suturing. Hemostasis is achieved, the blood pressure is checked, and this is how a neatly fibroid myomectomy is done in such situation. Now I would like to come back and ask Dr. Prashant Mangeshikar his view in doing this surgery in COVID times and his take on any guidelines which have come up, and when these patients come after the lockdown is over, what better options would be there?
Okay, as of now, all societies, including the ISG and the Indian Association of Gynecologists, we have laid down our own guidelines. They are on the net. No elective procedure is to be done during the times of COVID, and we will reevaluate again 2 weeks from now. We already had the second set of guidelines coming up yesterday, and,
yes,
it was well put in by the entire team that contributed to developing these guidelines. And Dr. Ganatra put them up on the website, showing very clearly that only emergency laparoscopy should be done, for example, ectopic or a torsion of the ovary. We do not do endometriosis or myomectomies or hysterectomies during this time. When the condition will be deemed safe to perform elective surgeries, it is mandatory now to use smoke evacuator devices. And you get two types of these devices, the active ones and the passive ones. The active ones are, again, they cost about 5 lakhs, whether it is BOA or whether it is Stotz or whether it is Covidian or Johnson & Johnson. But they also have consumables. On the other hand, you can develop your own passive evacuation device, which is basically consisting of PVC tubing, which is readily there in your operation theater. You use the pulse filter, which is used by the anesthetist to the anesthesia machine. They cost about 400 or 500 rupees, depending upon the company that makes it. They're readily available. These are carbon filters. And along with that, you require an ULPA, ultra-light particle absorption filter, which IVF people are very well aware of. They're made in India in different sizes, etc. They are much more easier, rather, they are much safer than the HEPA filter because it absorbs even the small microns and gives you 99.9% absorption of all bacteria and viruses. My take on these evacuators has been also because they carry Smoke, surgical plume carries carcinogens and mutagenic agents and toxic gases like toluene and a host of other 20 gases that would be there. Again, on the website, we have had this PowerPoint presentation done. And a number of my colleagues did develop cancer. Laparoscopic surgeons did develop cancer of the colon, esophagus, tonsil, and the throat. And therefore, one has to be wary that one must wear a mask in the theater. You must have proper PPE uniforms even at that time. And you can't be operating you can't afford to have a negative theater even in a corporate hospital. For reasons that have already been discussed on the webinar yesterday. So you require good circulation, which can filter, we can do a circulation 12 times an hour. So this is what one needs to be careful of. You need to ensure that all the instruments are either autoclaved or ETO sterilized. You can't be using Sidex, which anyway are not allowed by JCI or NABH. Technically, and you should use single-use instruments, only single-use. So you're using harmonic, you use it only once. But I don't know what the take is going to be, because I'm a little worried. I'm surprised that that harmonic companies say it is single-use and you should use it single-use. But in the same breath, the robotics also use harmonic, and that's allowed to be used 12 times. So for whom the cap fits. So I'm very loud in what I say. I know companies are listening to me and they're ready to gun me down, but they need to give an explanation. If the harmonic can be used on a robot 12 times, why use it only single use on the patient? Why not get it effectively clean, like what they do for harmonic? But anyway, we have to be careful. We need to wear a mask in the theater. Everybody has to wear a proper mask. You don't have to wear an N95, and it is difficult operating with the PPE suits, even to do open surgery. Now, at this moment of time, open surgery would be the call if there is a necessity for an emergency to be done, and not laparoscopic surgery.
I'm coming to the next question. She is a 35-year-old lady. Meenal, Sriman, can you put the next slide? This is coming to Dr. Prashant Mangeshikar only. So basically, we have got to use all the laparoscopic guidelines which have come up with IAG, and there are guidelines from the IAG and European Society. But this case is, sir, now 18-week size fibroid, and ultrasound shows 10 to 12 into 8 centimeters anterior wall fibroid. So would you like to go ahead with an open surgery or a laparoscopic myomectomy? Your take on that? And Dr.
You mean now or later?
Later on, post-COVID, after the lockdown goes, and still we have COVID patients probably coming for the next 2 to 3 months. We don't know. Lockdown is not actually that it tells us that COVID is gone. COVID is going to be here for a long time. But what is your take on this when it is a large fibroid?
Well, it's not really large. It's just 10 by 12 by 8 centimeters. And that's, I'm sure many laparoscopic surgeons who are experts, as we have in Bombay and in India, would even do this laparoscopically. It's only that one has to have suturing skills, and one has to be, I'm not worried about morcellation in a bag. I do not morcellate in a bag, because if you tell me that you're going to morcellate in a bag, it's like putting a condom on after sex. Patient's going to get pregnant. So when you remove the fibroid and park it on the bowel, if you remove the fibroid and park it on the bowel, you already upstaged the disease if the patient has a leiomyosarcoma. So I'm not, and the incidence of leiomyosarcoma.
Meenal, can you stop the sharing of the slides, please, Meenal? Can you please stop sharing? We want to see Dr. Prashant Mangeshikar's condom.
Condom. Okay. I don't use condoms. They don't give satisfaction either way, neither in the theater or otherwise. But anyway,
okay.
To put things in a proper perspective, if the patient is a leiomyosarcoma, even the act of the incision, be it at open surgery, is going to upstage her. So you're not really blaming the only problem is when the particles start flying around. That is when the dissemination of the disease gets worse. It's already disseminated with the act of incision. But if you are not careful when you are morcellating, And if the patient, God forbid, is a leiomyosarcoma, which is very rare, it's not very common that you see it, that you have to put everybody in a bag. And the time taken from excision of the fibroid to putting it in the bag, and you're putting it on the bowel, has already upstaged her, no matter what you do afterwards, putting it in the bag. So that is my call, and most surgeons would agree with me. It's only those who want to run after that bag will keep on harping that use a bag, use a bag. It's not so. So, but as regards the aerosols, maybe there would be a place then for that bag to prevent escape of the aerosol vapors to the outside. If from the port side the fumes are going to come out, or the debris is going to fly out. So these are things that need to be studied even more in detail. But as yesterday, Dr. Paul even mentioned, a 10 centimeter fibroid can be taken out not by morcellation. You can take it out vaginally, and we are gynecologists, so we are good at our vaginal skills, and you can take it out vaginally. So you don't have to worry about. Only thing is, at that time, you need to deflate the abdomen with a suction cannula. Do not press the cannula and blow the air out into the theater, because that's going to cause rapid spread if the patient is harboring. And at this moment, there's no evidence to show that the COVID is there in the aerosols. It's only an assumption.
Niranjan, can I just add? I think I do understand Dr. Prashant Mangeshkar is a fantastic laparoscopic surgeon, and we have got others. You are a good surgeon, especially in Gondor. But sir, my advice is, right now in this acute pandemic stage, for another 2 weeks, till
don't do anything.
Don't do anything. Please use medical management. Manage your patients. Very rarely you will have an emergency hysterectomy. It is not the routine. Now suddenly I find people are telling emergency hysterectomy.
Yes.
Please use medical methods. Maybe 2 weeks down the line, we will understand. We will see what is happening. Then we take a call. I think that should be the way we look at.
Shanta, at this moment of time, it reminds me of Professor C.G. Saraya, who was the teacher to many and the president of the Bombay Society. Many years ago, he said, if the patient is in labor and the doctor is a little late, then he will end up, when the patient is fully dilated, he'll apply a forceps and come out. If he lands when after the patient has delivered, he'll do a manual removal of the placenta. Okay, so that's why the emergency is a figment of imagination of the brain of the gynecologist wanting to get his itchy hands on the patient. So, right? So I asked everyone, how many times have you really encountered pre-COVID area?
Yes.
Emergency.
So you're absolutely right. Friends, all the viewers, we know all of you are fantastic surgeons. In once you know cycling, you'll remember cycling throughout your life. If you don't operate for 2 months, you will not forget your skills. So please be a little patient. Enjoy the lockdown period. Only treat patients in emergency and use medical methods. And I'm sure after this acute phase passes over, all of you can actually subtly take care of your itching fingers.
Dr. Prashant Mangeshkar, you answered very well regarding the guidelines and how Indians should go about treating such cases. And Dr. Shanta, you also summarized it very nicely about going very slow in such circumstances of lockdown. Dr. Krishnendu, you are very silent today, so we want to hear some comments from you. But let's not go in the machine, or let's not go in some another
molecule. No. I agree with what Shanta said, and I mean, it's no point in repeating and prolonging the question. But the point, what I'm going to say is, Prashant has dealt everything very beautifully, and he's the master here as far as endoscopic surgery is concerned. So he really has the last say in this. But what is important is, be patient. Try to only operate on patients you have to and cannot run away. And I feel in our case, it's obstetrics, delivering the babies. And as Prashant earlier said, if an ectopic comes, or a torsion of an ovarian cyst with unbearable pain, then I guess you have to. Otherwise, I think it's better to just, masterly inactivity.
Yes.
Masterly inactivity is the right word, Krishnendu. We were waiting for that word to come, and you scored it. And it was amazing. And I would like to reiterate here, Dr. Yoon is a speaker, a very well-known speaker, a master on HIFU, and he runs a center on Korea. I would like to reiterate here, he is not a representative of HIFU, he is not an employee of HIFU, and we should respect that his experience of treating this fibroids is amazing. He is one of the pioneers in Southeast Asia. Thank you for your expert advice to us and the way you have spoken with a wonderful lecture. Dr. Shanta, mic is yours.
Professor Yoon, I want to know, in Korea, yes, all your women want to keep the uterus in. How many of the gynecologists in your country prefer to do HIFU over doing surgical management?
Still, there are more doctors so they recommend hysterectomy rather than HIFU because the machine is too expensive. Maybe similar to the Da Vinci open surgery, I think. But in university hospital, doctors, they not only OB/GYN doctors, even also the radiologist or general surgery, urologist, they can use the diabetes together, right? But normally the ultrasound guided HIFU is controlled by only OB/GYN doctors. So that's why the university hospital doctors, they do not decide to buy the ultrasound HIFU. So I think even there are so many myoma patients, I think maybe 80% of patients get the hysterectomy, not HIFU. But one of the reasons is that they do not know. Even we try to explain the HIFU of the advantages, but many patients do not know about the HIFU. So we want to spread the knowledge of the HIFU to the more patients who didn't get the information about that.
Yeah. So
that is my final, yeah.
Thank you, Professor Yoon. I think, but as Dr. Krishnendu sir also told, the cost of the machine is high. But now I think post-COVID, now we are looking at how in India we can make cheaper and cost-effective machines. So I'm sure India will come up with an cost-effective machine which may help our women and our gynecologists.
Shanta, I think I would like to interrupt here. You know, every time a new technology comes, there are always people who are, skeptical of it. But I think today, after listening to Dr. Yoon, it was really wonderful the way he's mixed HIFU with surgery, and it can become easier. I mean, what he's talking about is that the expertise level required sometimes can be much, much lesser by reduction in the size of the fibroid, reduction in time of surgery, reduction in the blood loss, etc. So I think it's a wonderful technology. We should not put it away completely. I think
agree.
It may be time to integrate it with our medical therapy, with HIFU, with surgery, and we'll be able to give our patients, finally, what is important is that the patient has a fantastic recovery, fabulous, everything is treated properly. And I think with the technologies advancing, with IVF advancing, I think this is a very important thing, a mixture which you brought about. I think, Niranjan, I must compliment you that it was really beautifully talked about. We have, surgery, medicine, everything. And I think it's really, really important that we integrate all of these in our practice to see what suits the patient best. Because finally, let me give you an example. One of my patients had a problem. It was life-threatening, and the doctor says, "Oh, but that particular treatment is expensive." The patient's relatives looked up at the doctor and he said, "Look, you don't have to worry about the cost. You saved my wife." Because they could afford it. So I think we have different classes of patients and different people, and some would prefer medical therapy, some may not want to undergo surgery. So I think we need to keep our minds open to accept these different modes which are available to us in today's practice. And let's not only go on cost or only surgery or only HIFU.
Madam Nandita, Shanta, Prashant, Krishnendu, I want to tell you here that we have got more than 4,700 members logged in just to see all of you. And I am not saying anything else than this. We have got Dr. Pardesi. He is a man from Marathwada. He is in waiting. And I want to say here that Dr. Krishnendu, there's one doctor who also wrote last time. She is a great fan of you, and she is also joined here Dr. Banerjee, she's from Kolkata, and we are very happy that you are, talking so nicely, especially that word of masterly inactivity. Thank you, Nandita. Thank you, Dr. Shanta. I want to tell today, when we have Rekha, when we have Hema Malini on the same platform, and Danny and Amol Palekar, why would the picture not be a hit? Tell me, Dr. Shanta.
It is Bahubali 3.
अरे यार हमको रेखा और हेमा मालिनी बना दिया मेरा
चलेगा.
Recipes Prashant.
Prashant is hiding them.
I think Niranjan, you have to explain a little bit about this to Dr. Yoon. Otherwise, he's going to get confused about Bahubali, etc.
Dr. Yoon, we would like to tell that Bahubali is a famous movie which has come in from south of India, and it has gone all over the world. It's one of the best movies which Indian, the film industry has made. Thank you.
Okay.
So we go to the next question now.
Oh, that's question.
Okay.
We have Pardesi, sir.
There are a few questions which are there, and we will come back to Dr. Pardesi later. Dr. Krishnendu, can we have the case number 6? Yes. Dr. Krishnendu, this is your case, please.
Okay, in a 13-year-old girl with menarche 2 months ago, what is the commonest cause of AUB in adolescence? I think this is a very straightforward question. We all know that because of the immaturity of the hypothalamo-pituitary ovarian axis, we have this problem. And I think one of the most important things that we would like is to counsel the parents more than the little girl there. And I think counseling is very important, building up her hemoglobin. And one thing which I always do is deworming them. I believe in that very strongly, especially in young adolescents. And if really there is a kind of, excessive bleeding, menorrhagia, puberty menorrhagia, as we call it, then we can definitely give them medicines like tranexamic acid to take care initially. And very, very, very rarely do we have to add hormones. So I think this is really kind of a straightforward case, but I think it's very important that we do these things and counsel the girl also, because they're very scared. She'll be very scared about suddenly why she's bleeding for the first time, and heavily on top of that. This is the way I manage a young girl of 13 years who's kind of had abnormal uterine bleeding.
Would you give her hormones if required, Krishnendu? Because if tranexamic acid doesn't control it, how long would you give?
That's what I said. So if tranexamic acid does not, then you have to give a very, very mild dose of norethindrone enanthate, or norethistron enanthate, and nowadays you have the control release format as well. But it's always better to try and avoid hormones as much as you can in such. Of course, you have to rule out other, if very rarely if she's got some, blood coagulation disorders and stuff like that. But that's really looking at it with just one episode. 13-year-old, just 2 months ago, she's had a menarche. I think we should not think of these horrible things and think of normal things and be humane and.
Okay. Thank you.
There are many questions which have been lined up now. Now the audience have gone to 4,800. I got about 150. To be precise, 174 questions. We will try to get as many of them.
Are we trying to be here till midnight?
No. We will finish this within half an hour. Don't worry.
Okay.
And I'm trying to get all those questions the best I can get. But thank you, all of you. Dr. Shanta, would you like to share your experience of adolescent girls coming with puberty, menorrhagia, and how would you manage these cases? Krishnendu has very nicely explained. In the meantime, I will just arrange the questions, please.
I think what Professor Krishnendu sir has told was absolutely correct. And the most important is you have to actually think about is the nutrition in these adolescent girls, because many of them have a lot of nutritional deficiencies. Many of these girls, young girls, are having anemia, and so you need to supplement along with the advice which you give them. You have to actually do more of psychological counseling, and just be very nice to them and tell them what is the proper diet, to have. Now, like how in the COVID time, everybody is going back to the basics. making food at home and trying to reduce the, I mean, there's no choice. There's no fast food. So I think that nutrition is a very important aspect, along with the counseling of the mother of the child, along with the adolescent, which is very, very vital. And a few months, usually it will settle. Otherwise, we can put them on hormones if needed. Cannot hear you.
Niranjan, we cannot hear you, Niranjan.
Yeah.
I would like to hear from you the role of Dynogest, which has been used in cases of post endometriosis cases, post-operative endometriosis cases, or would you like to just go ahead before doing IVF or after IVF use of Dynogest?
Yeah.
Dr. Nandita, madam.
Unmute. Unmute.
Yeah. Okay. Yeah, hi. Sorry.
This is regarding that case which we were discussing about IVF.
Yeah.
And I wanted your opinion about use of Dynogest in such circumstances. You had told about use of progesterone, but there is a question to you. That's why I'm coming back to you, madam. Please excuse me. This is regarding use of Dynogest.
Yeah, so I personally like the molecule Dynogest a lot. It's very, very good. So if my surgery is done well, I'm completely sure that I've eliminated the entire, the small deposits, etc., what we were talking about. Then you don't need any post-op therapy. But most of the times, there are some lesions which you probably may not have touched or may not have seen. Then it would be nice to give Dynogest in the waiting period. Okay, with Dynogest, what you have to do is you need to get at least 2 periods before you start IVF again. So that I would wait typically for 3 to 4 months, especially in a 33-year-old, even 6 months, before I start my IVF in this girl because of a low AMH. But also you can give her an attempt to try naturally if she's just been married for a very short while. But when you give Dynogest, you cannot have conception. So it depends on what plan you do. If you plan to let her conceive, then leave her alone. I would do an IUI along with it rather than, IVF. But if you plan not to conceive, then I would like Dynogest for 3 months and then give her get the period after Dynogest, another period, and get on. There are oral contraceptives also with ethinyl estradiol with Dynogest also. Those also can be used in these patients.
Oh my God! I'm in disbelief. There are audience which have come from Africa, Algiers, France, Germany, Southeast Asia, China, Malaysia, Singapore, Thailand, and apart from this, our SAARC countries. There's one guy, madam. I want to ask you this: Chuk Won Vaike Odiga. I mean, it's very difficult for me to pronounce. He's from Kenya. What about he or she? I don't know. I'm really sorry. Please, what about the LH suppression and long protocol in poor responders?
Okay, I personally do not like the long suppression in poor responders in endometriosis. What I prefer to do is I go and make the embryos and then give the long suppression, GnRH analogs before the frozen thaw ET. So that is how I prefer to do it. That's the way I would prefer to do it, not give it stimulation because it causes oversuppression. The amount of gonadotropins that is really required is a lot.
Yeah, there's one more question by him. In an agonist cycle using depot agonist, any concerns about more menopausal symptoms or higher gonadotropin requirements?
Yeah, definitely the higher requirement of gonadotropin is there when you use a depot. Nowadays, most of the units have stopped using the depot as a drug for stimulation. So we use either daily injections of agonist or just the puff which is used. But I would suggest that if you want to reduce the consumption of gonadotropins, please go to antagonist cycle.
Okay. One more question, Madam Nandita. This is from 1 minute. The name is not mentioned here. I will get the name, but if in first case bleeding continues after 21 days of norethistron, how many cycles do we give norethistron? And what is the effect on fertility treatment? How norethistron will affect ovulation induction, alternative medicine or postpone?
See, I like norethistron to be washed out of the system before I start ovulation induction. So maybe wait for a period or 2 periods. But if norethistron along with tranexamic acid doesn't work, then a lot of times I switch to high doses of estrogen and progesterone. Then if that doesn't work, the third choice is a GnRH analog injection. That really works wonderfully. So these are the 3 ways in which I would do stepwise treatment for an infertile patient.
Thank you. Thank you, Dr. Nandita. Dr. Shanta, there is one more question for you.
Yes.
It is regarding a 25-year-old girl who is unmarried and she has multiple fibroids, okay, ranging from 2 to 3 centimeter to 4 to 5. And she doesn't want laparoscopic surgery. She has come to you. Please advise, how would you go about it?
So she's 25 with multiple fibroids. Ideally for this patient is to put her on a medical treatment. Now with the dilemma of which drugs to put, but as Dr. Krishnendu Gupta has told, we need to do a baseline LFT before we'd like to try the drug which is to be used, or if she's having bleeding. See, excessive bleeding, you correct the hemoglobin. Usually they will be anemic. They will be settled down. And again, GnRH agonist injections are also not very effective in these patients. Okay, so you'll have to buy time and try the medical therapy, and as the symptoms increase or if the size of the fibroids increase, then you have to offer that lady surgical management.
Shanta,
You can try mifepristone
Yes,
also.
Dr.
25
Krishnendu,
milligrams.
after that, Dr.
Mifepristone, many
Prashant
studies-
Mandeshikar will speak. Dr.
Yeah.
Krishnendu, please.
No, I said you can, if like as she said, GnRH analog, and if she doesn't really agree to that, mifepristone can be tried. Although there are multiple fibroids which gives to problem, but as you said, the choices are very minimal. So ultimately, you have to sit and really again, counseling is very important in such a case. Make
Dr.
her
Prashant
understand that this is
Mandeshikar? Yeah, Prashant sir, you
let me come back to the recommendation by the United Kingdom Drug Advisory Board or
Yes.
committee, whatever it is. They said the LFT has to be done in
Yes.
patients who are already on that ulipristal. Don't
Yes.
stop it if they're doing it, but do not recruit any new patient for ulipristal. That is across the board. They had a grand.
See, we can't hear you, Dr. Prashant. But what the directive was for our patients was always do a LFT. If you already put your patients, follow up with the LFT. As long as the LFT is okay, you can continue. But
That was then.
Yeah.
Okay, the drug controller of India, okay, is probably still involved with the COVID.
Now too much of COVID. So let's wait till
Okay.
the COVID is over and
So
then take a call.
they're busy with that. So they're
About the surgical aspects of this woman, what would you suggest? How will you convince her multiple fibroids? You have muted your
Dr.
phone.
Prashant, there is some technical issue. We will come back to sir. I'm going to the next question now. Dr. Krishna Kumar has joined. He is our president-elect of IAG. Welcome, Dr. Krishna Kumar. He has asked the question, Dr. Krishnendu, management of type 2 submucous fibroids. Sir, it is a very lengthy question, lengthy answer.
I think he knows the answer also, being such an expert.
Yes.
I think we'll leave it at that. Let's move forward to more standard questions.
Yeah. Thank you. There is Dr. Tapan Kumar. Can SIS be an alternative to hysteroscopy in AUB? Dr. Prashant, this question is from you, Dr. Tapan Kumar Mandal. Can SIS be an alternative to hysteroscopy in AUB?
Now, how is hysteroscopy going to be replaced by SIS? Because it's not a therapy, right? It's just a diagnosis. And with the good ultrasound, which give you 3D imaging, you don't require SIS for that. You should have a good eye to look inside the cavity with the 3D ultrasound. So, but if one wants to do SIS, well, you can do that. But I think most of the polyps can be picked up with a good 3D ultrasound. Right? So
Thank you, Dr. Prashant, and I would like to thank Dr. Krishna Kumar. He is viewing us. That is the most important thing, and that matters most to us. That's why you have joined to see all of us, and we thank you to join us. We go to Dr. Saika Zahu. She is asking latest guidelines for use of LNG IUS in the management of AUB in perimenopausal cases. I think this is also too lengthy. We have already explained what are the things, and we would not go to the next question is by Dr. Reena. Which progesterone would you advise and how much is the dose and for how long? Dr. Shanta, can you take this question, please?
Yeah.
Regarding which progesterone would you advise and how much is the dose for how long in cases of AUB?
See, you have to, for AUB, the first course of progesterone, the norethistérone which you try, you should not use it indefinitely. The advice is use it for one cycle till you stabilize. And then after the acute phase of bleeding is over, you can shift out to other medroxyprogesterone acetate, which are there. And then now some of the cases which we find that even this Dionogest molecule also helps. Though it may not be in the acute phase, but in the maintenance, it helps. And of course, the other one is the LFG intrauterine system. But
Thank
remember,
you. Yeah. Thank you. Dr. Nandita, I would like to tell you that question which was asked to you regarding norethistérone was none other than by Dr. Bharti Maheshwari from Meerut, your biggest fan.
I'm her fan. Fantastic worker.
Thank you, Dr. Bharti, for joining with us. And we find many of Foxians who are there. There are many questions which are pouring. There is question. Dr. Yogesh Shinde is asking, ma'am, what is the maximum dose of norethistérone for HMB daily? This is for Shanta, madam.
See, norethistérone has been used like the peppermints or like some chocolates and all. But please be careful. Don't use before we used to say 5 mg TID, you increase it to 10 mg, but depending on the patient's response. The first 2 days you have the higher dose, and then when the patient is, the symptoms are reducing, you taper the dose of the progesterone in 2-3 days, and then daily 1 tablet you put them on maintenance. But please don't use it indefinitely. We have seen patients being put for months together, and the other point is some of us don't have time. So we write for them, some of them are writing about 15 or 20 tablets. They say 3 times daily for 2 days or 3 days, they're followed by BD. And then they're actually supposed to be put on some other maintenance for 1 month. The patients miss it, they use the 15 to 20 tablets, the bleeding stops, and again, after 5-6 days, they have the withdrawal bleeding again. So you have to put them on maintenance for 1 cycle for 21 days. Dr. Krishnendu as an...
Madam,
I just want to just
for explaining. We have got now, since the question answer session has started, we have got 4,800 members have logged in. Dandita, madam, there is one question to you regarding the same case which we discussed, case number 1. Can IVF be done without surgery? Because that case was about 5 centimeter endometrioma, and I want whether we can go ahead with an IVF directly because the other ovary is normal. Can you unmute, madam, please?
Me back. Okay. Can you hear me now? I think,
yes,
if my patient is married for very long, the duration of marriage is longer, I would like to get her pregnant as soon as possible. Now, there is a scenario where you have a large endometrioma, so that particular ovary may not respond to your stimulation. And she has a low AMH. So it's a dilemma. But what you can do is you can stimulate the patient and see if she's giving you oocytes. In a 33-year-old, I was just attending a beautiful seminar and I just read about it, that in a 33-year-old, you need only 2 blastocysts to achieve a pregnancy because about 60% of the blastocysts are euploid in a 33-year-old. So if I manage to get 2 blastocysts in just 1 stimulation, I'm giving her a chance at pregnancy. So I think you could go in for a stimulation without surgery, but remember that post the pickup, you must give GnRH analog 2 or 3 GnRH analogs before you transfer, because yes, that will help you in the ameliorating the effects of the endometriosis on the endometrium. But if you've done, like I've had a case where I've done 3 IVFs and she's, embryo transfer and she's not conceived. I've done surgery and then she has conceived post it. So the jury is still out whether surgery is better or medicine is better. And this is a, beautiful debates going on, fertile battles they are known as. And it's fantastic the way data has been put for the surgery and for IVF. So it all depends on how good you are. I'm very good at IVF. I would get this patient pregnant without surgery if I get eggs. So it all depends on what you are. If there is a surgeon who is very good at surgery, he'll say, I'll get the patient pregnant by doing surgery. I mean, both the ways work. If you ask me, I would prefer to do IVF.
Thank you. This was Dr. Reva Singhania. Thank you so much. Now we go to Dr. Yoon. This is a question for you, Dr. Yoon.
Yes.
Usually the vaginal discharge persists for how many days after HIFU? Dr. Reshma Krishna, she wants an answer for this.
The question again, please.
Yeah, usually how many days the vaginal discharge lasts?
Vaginal myoma.
Treatment.
You mean vaginal myoma, right?
Yeah, vaginal discharge.
No, we cannot treat the vaginal myoma by the HIFU.
No. The vaginal discharge which is there after a HIFU treatment, how many days does it last?
The signal is now the.
Do our patients after HIFU treatment have any vaginal discharge? Do they have any white discharge? When the fibroid is shrinking in size and when we are using HIFU after 3-4 sittings, the question asked is whether there is any discharge.
Okay.
Oh, yeah.
Vaginal discharge is I show guys the article paper. The data was 8 point something percentage, I think, but I think it's more than that. I think I usually explain to patient after HIFU, the vaginal discharge will be come up around 20 or 30%, but the color is brown, not reddish, brown or dark red. So I usually say, don't worry about it. And then we don't need to treat or we don't need to give her the medication. It will disappear within the 3 weeks, I think.
Dr. Yoon, just one doubt. I think what also the delegate who signed in wanted to know is how long does this vaginal discharge continue after a HIFU?
Yeah, 3 weeks.
3 weeks, okay.
Yes. And then it will be gone. Normally, it can go longer, but it will not exceed more than 6 weeks. Thank you.
Thank you.
Yeah. Dr. Prashant, can we have your comments, please? Dr. Prashant.
Well, I need to leave now in 5 minutes, but I just have one comment. First and foremost, thank you for involving me in this program. And since mid-March that the lockdown took place, it would be a good idea to have a survey of the IVF people to see how many of their patients. Hello?
We can hear you.
Okay, I just wanted to, it would be a good idea to have a monkey survey for all the societies that are involved, whether it's the FOXI or the ISAR or the IAG, how many patients who would have been scheduled for IVF now, but did not undergo IVF because of the COVID, how many of them got spontaneously pregnant? It's a good idea.
Yeah, I know. It's a good idea to check whether the surgical patients also need the
No.
It's the same case. Come on, Prashant.
Exactly. No. Since I do surgery.
I mean, there are patients. There are patients who have spontaneous pregnancies. I totally agree with that.
I think what we should learn in the COVID period is to have patience. Be it IVF, be it laparoscopy, be all the gynecologists. Learn patience, be best. Remember, go back to your basics. Okay, and then after the lockdown is over, after COVID is over, you all can practice everything will go back to the normal.
Thank you. Yeah, I'm there. Thank you so much. Madam, can you hear me? There is Dr. Naresh Marepalle. How do you manage subserosal fibroid size 3 into 4 centimeter? Will it affect pregnancy? Any chance of red degeneration? Dr. Krishnendu Shanta can take this.
Krishnendu sir is there.
What's that?
How do you manage subserosal fibroid of size 3 into 4 centimeter? Will it affect pregnancy? Any chance of red degeneration?
No,
Dr.
if it's,
Naresh
yeah, if it's before, if someone is trying to get pregnant, I think it's better to get it removed before you attempt pregnancy. And once someone gets pregnant with a submucosal fibroid, we all know because of the fibroid itself, because of the micro contractions and all that, whichever it does, there could be a chance of spontaneous miscarriage in this. So I mean, I think counseling is very important. So red degeneration and all will come much later, if at all. But my point is, when is the patient coming to you? Is it before she's trying to get pregnant or already she's pregnant?
No, here it is not mentioned that way. It is not mentioned that way.
Yes. Niranjan, I was.
I can't actually. There's a little bit the problem.
Can I talk, Niranjan?
Yes,
yes, please.
I was just going through the internet on my phone about ulipristal. Okay, what is the latest thing and all? The thing that I found was that in 2018, Allergan's FDA approval was rejected. But since then, they have done the Venus trials in America, and it's a drug under evaluation. Okay, and they've done the Pearl trials. So more than 1,000 women in Pearl trial. Even in Venus trial, there were a lot of women which were taken, and it has been sent for approval. Remember that short term is something that you can think of. Okay. The other thing is that what Chanta said was very important, that the LFT should be done before, and I would do an LFT afterwards, and we don't use it for more than 3 months, especially in cases like this. So we have to be a little more, more
liberal in our thinking.
And there is I was also talking on the other side that there is a drug drugs which cause liver damage. And what has been found is this particular ulipristal doesn't belong to that category. I forget what it's called. It's got some short form acronym. But what the liver toxicity, which they have seen recently, is an idiosyncratic reaction of those patients. Not everybody has it. So that can happen with any drug anywhere. So yes, the jury is still out, and I think, but we've been using ulipristal without any problems, and it's for a short period. Remember that. Yeah, Shanta, you want to
Nandita, actually, in fact, I've been traveling the past 3 years. Like, I think I have touched many societies across and in many places, in fact, and I had always discussed with you, the patients who pre-IVF, your results with ulipristal were extremely good. After that, I was actually advocating pre-IVF small multiple fibroids. That case which actually came. And now in the COVID period for 2 months or something with an LFT, I don't think we are wrong. See, we are not telling that. See, now we are using some drugs, hoping that it may work. But we have to be cautious. And definitely we need to wait for our guidelines before we say something is correct, something is not correct. It's high time that we say that we don't no longer only go by the studies of the other countries. Our country, our perception, how we manage, because our human life is also important. We are worried. I am very careful about my patient's life. And Indian life is also as important as any other countries. So we are all very worried about, and we want to take care of our women. And I'm sure all of us are very particular to safeguard our women's health.
Just to take care of them, because I've had a lot of patients, multiple small fibroids, no implantation failure, and used ulipristal, and they've got pregnant. So I think somewhere we have to. It's not for everybody. Yes. You have to select your patients which are indicated for different things. And I'm really happy listening to Dr. Yoon today, because it was a fantastic mixture, of technology, of surgery, of medicine. I think that is what we need to open our minds to. It was real. I'm so happy I would listen to you, Dr. Yoon. I'm really, really excited about it. And there are so many technologies, Niranjan. There's Bizblade. There are lots of technologies. Surgery is going to go away. You can just put in a needle and lights that with different energies. There's cryo, there's ablations, there is microwave energy which people are using. I mean, we don't talk about it because it's not available in our country, but it is been available in US. And I think there are different ways in which fibroids, and for all you know, after some time we may be doing a genetic twitching and the fibroids will dissolve. Sorry, surgeons.
No, but I think, Nandita, what we have to understand is most important. This COVID has taught us is prevention is always better than cure. I think we need to look at it how we can prevent the disease coming or some disorder coming. So we need maybe that preventive aspect, which would be better than trying to show that we are the best of the surgeons. I can remove the 36 week size fibroid, or I can remove some 100 fibroid for the Guinness record. I think we have to see how best we can minimize any patient being exposed to the knife. If possible, treat them medically. Don't tell them that only surgery is the messiah of truth or only surgery is the way out. Offer them. It's your responsibility to offer them the different. You can tell them you can have this HIFU, you have the medical management, especially those who don't have. Every patient is not going to have a leiomyosarcoma. We all got, I think emotionally or psychologically affected by all that. So I think that's how. Krishendu sir, I need your opinion in this. He's been giving me his.
I was going to use the word paranoia.
Yeah.
the way you.
I love your one-liners.
Yeah.
But I think really what Nandita said regarding Dr. Yoon, it's fantastic. I mean, we really saw something. We really could actually experience the benefit your patients have got by this new modality of therapy, which is really great.
That's
Dr. Yoon, we'd like a word from you.
Sorry?
Dr. Yoon will now tell his opinion about this webinar. We are still live. We are still live. Delegates are listening to this conversation. Yes.
And I will present more case presentation with the image of the MRI, and then please call me again. Thank you.
Oh, great.
Did you enjoy being with us? The different thought processes, everybody's different views. I think that was interesting, wasn't it?
It was great experience, and I learned so many things about the patient because you guys are #1 doctors in India, right? So it's an honor on me. Thank you.
Dr. Yoon, should I tell you one comment? I have cheating on the webinar. I'm on the WhatsApp also. All my friends all over are sending messages that it was a very informative webinar. Professor Yoon has told us the use of this non-invasive technology and then the medical management. It's a fantastic webinar. So all of you, I believe, are doing a fantastic job. Niranjan, you're doing a very good job.
Thank you.
And I'm
Niranjan,
very happy.
Thank you.
Very proud of you.
The opportunity is really great.
Madam, I would like to take this opportunity to congratulate all of you that the whole idea was to get different streams of obstetric and gynecology on same platform, and that's why we have IVF, the #1 consultant from Bloom IVF, Dr. Nandita, Dr. Yoon regarding HIFU. Then we have endoscopic surgery, Dr. Prashant Mangeshikar. And then we have Dr. Shanta and Krishnendu who are doing general open surgery as well as endoscopic surgery and as well as doing coronavirus. So, madam, it was a wonderful idea that all of you agreed, and I will tell you 5,000 people are still there and it's live. I'm telling you, madam, it is super amazing, and thank you so much, all of you.
Can I just tell one point? There was when I started off as an open surgeon and then I converted into a laparoscopic surgeon. You see, we had learned the techniques of good surgery in our undergraduation and post-graduation in Manipal. So we were taught and we learned how to do the surgeries by laparotomy. And then it was very easy to pick up a skill of a laparoscopy. But what we find in the present generation, people love to be minimalistic surgeons, only laparoscopic surgeons. Now, if in this COVID situation, now you can imagine what is the plight of our youngsters who are actually not mastered the art of open surgery. So this is a lesson for all our young budding gynecologists. Please master the technique of open surgeries. And then definitely you can become a lab surgeon, you can become a robotic surgeon, you can become a space surgeon also. So whatever it is, but your basic is very, very important. Your surgical basic skills are very vital. I think this COVID-19 has taught us that we need to go back to the basics. So all
Madam,
professors, please teach.
Yes. Shanta madam and all of you, we have still questions. It is not ending here. The sponsors have said Alembic, we should appreciate them that they have agreed to get all those people from different platforms, and they have agreed. They are a medical pharmaceutical company, but still they have agreed, and we should thank them and thank TOG. TOG has been the #1 live webinar show, and I thank you that you come again, and we will have wonderful time. There are many questions which are still there. There is Dr. Manipal Hospital,
With your
Bangalore.
permission.
Dr. Murlidhar Pai is writing, just let me complete. Manipal Hospital, Bangalore has HIFU. Even Delhi Hospital has got HIFU. And there are many questions. Mamata Devi is writing about AUB in teenagers. I think we have got a lot of questions on teenagers. 30% of those cases are having questions on AUB on teenagers, and they are there from Minark onwards. I think we have already discussed the management and we have already talked on that. Thank you, Dr. Mamta Devi. Dr. Krishnendu, you wanted to add something. Please go ahead.
No, I was not going to add. I was just going to highlight that point with which my dear friend, Dr. Murlidhar Pai from Manipal had written, that Manipal Hospital has got HIFU.
And
I want to highlight that point.
Yes. And I think Murli sir is there on this thing. Again, thank you for Manipal, of course, Krishnendu sir, Pratap sir, and you all have actually instilled the art of good surgical steps. That's why I think we all have become good surgeons. And now even in the COVID time, when they say you please don't do laparoscopy, we can still survive with our laparotomy skills. So that is very important. And thank you to Alembic. The whole team has done a fantastic job for getting so many people on board. And let me tell you, Science Integra, Niranjan, I never used to like webinars before. Let me be very honest. But now you have made me enjoy the zooming.
Madam,
I didn't want to get onto the webinar today. Niranjan, I told him.
I know.
Madam, I have called you 3 times today. I have called you 3 times, but thank you for being there. I know Sunday evening it was your suggestion, and I would like to tell you, madam, you are Hema, you are Rekha, there is Amol Palekar, there is Danny. I don't know where I fit in this, but to be on a little serious note, we lost 2 gems of, from Bollywood industry. We had our 2 gems of, artists, actors who unfortunately were no more. So it is a serious thought, and we are also warriors. They have been entertaining the film industry, and in the film industry, they are entertaining all the audience, which we are also part of it. And I'll tell you, this COVID has taught us that you are nothing less than a bigger film stars of obstetric and gynecology, and we want you to be there. And on a somber note, on remembering them, we should also thank that all of these things end soon as possible. Every one of us go back to our lives, and all of our warriors are safe. And I would like to thank Shanta madam that you gave us that video to be played for the honor of those Corona warriors. And I know, Nandita, your team is still there. There are 10 to 15 centers of yours there, and there are still your IVF consultants who are still handling those situations, taking telephone calls, taking those video calls, directing them how to go about, because anxiety, stress, and a lot of things. And thank you, Christian. You also told me that since morning, you have been having a very, very bad time in your hospital regarding dealing with coronavirus. I would like to add here also, from my hospital, we have started getting obstetric normal deliveries cases coming positive. So we have got 40 patients of positive coronavirus in our ward.
How many?
Yeah, in our ward.
How many?
40.
40. So we have usually 25 to 30 deliveries a day. So last 1 week, we have got each unit 6, 7 cases, which have come positive. So we are discharging them. Most of them are asymptomatic and they are being told to be in home quarantine. They have been stamped on the back of their hand, and that's what we are doing. So there are a lot of things to be done. Thank you, doctors, for your valuable time. Thank you so much.